Mehdi Hamadani. I'm the chief of hematological malignancies and at the Medical College of Wisconsin, and I'm also the associate director of clinical research in our cancer center. Pertinent to the article you have, I am the protocol officer of the BMT CTN 1506 protocol, and this MRD paper is a secondary analysis from that clinical trial. BMT CTN 1506, also known as the MORPHO clinical trial, was a large placebo-controlled international randomized study that was conducted in collaboration with BMT CTN and Astellas Pharmaceuticals. The study was designed to evaluate the role of maintenance therapy with a FLT3 inhibitor, gilteritinib, in FLT3-ITD positive acute myeloid leukemia patients who were in their first clinical remission, which we call CR1, and undergoing an allogeneic stem cell transplant from any available donor with any graft source and any conditioning regimens. So when we were conducting BMT CTN 1506, in the early part of the enrollment of this trial, there were two trials that were published. One was called the SOAR-MAIN trial from Germany that looked at the role of sorafenib as a maintenance therapy in patients with FLT3 ITD positive AML, as well as a trial from China that asked the same question. The reason we thought 1506 was an important study was number one, our study was the only study that limited patient enrollments to patients with AML in their first complete remission. And one of the main differentiating features of our era of the study was we were in an era where FLT3 inhibitor-based induction treatments were becoming part of routine clinical care. So the question that we were interested in was, is FLT3 inhibitor maintenance needed for all AML patients? Are there patients where this maintenance therapy may not be needed? So one unique thing about the study was when we designed the study, one of the variables on which we stratified randomization was the ability to detect MRD in the peri-transplant bone marrow specimens. Because one of our working hypotheses was that if you received induction therapies containing FLT3 inhibitors and you entered transplant with an undetectable MRD state, maybe those patients don't need maintenance treatments. So when we look at our primary analysis, those were published in Journal of Clinical Oncology. It showed that in the overall study population, the primary outcome of the study was relapse-free survival, and in all comers, the study just missed statistical significance, but it is fair to say that in all comers, we were not able to show a statistically significant relapse-free survival benefit of gilteritinib maintenance. But notably, we noticed that in patients with peri-transplant detectable MRD, whether the MRD was detectable before transplant or after transplant, there was a clear relapse-free survival advantage present, which aligned very well with our hypothesis that maybe patients who are in a deep remission post-transplant, they don't need maintenance therapies and all the toxicities associated with it, but there was a clear benefit of adding that post-transplant maintenance in patients with detectable disease. The takeaway message is, like most things in life, one size does not fit all. Number two is a clinical message. If you are doing a risk-adapted approach for maintenance therapies in FLT3-ITD mutated patients, please make sure that in your programs you are using the right MRD assay. The assay that we used for 1506 is an in vivo scribe highly sensitive MRD assay with sensitivity going down to 10 to the minus 6. If you have access to that assay, then in our program, our approach is that we use maintenance therapies only in patients with MRD detectable disease. And in patients without MRD detected, we do not use maintenance therapies. This I would acknowledge is a little bit of an area of controversy, but these FLT3 inhibitor based MRDs treatments come with a degree of toxicities. They're associated with cytopenias. Potentially, those cytopenias may be associated with risk of infections. And there are data to suggest that these FLT3 inhibitor-based maintenance therapies increase the risk of chronic graft versus host disease. And those trends were seen in the 1506 clinical trial, cautioning against the blanket use of these treatments. But in patients who need it, and if you have access to the right MRD assay, I think these therapies are needed in patients with detectable MRD.